Good morning, ladies and gentlemen. My name is Denny Brennan. I'm the Executive Director of the Massachusetts Health Data Consortium. And I'm going to give you folks and the folks who are waiting to join our conference a few moments, and we'll start in probably less than a minute's time. All right. Thank you all for joining us today. My name is Denny Brennan. I'm the Executive Director of the Massachusetts Health Data Consortium. And I'm very pleased to welcome Dr. Clara Filice and Sarah Kinn from MassHealth to talk to us about data standards for sexual orientation, gender identity, race, ethnicity, language, and other critical elements that comprise creating a foundation to measure and manage health equity. Next page, please. Just a few audience reminders for folks. If you are following us on Twitter or are one who likes to live tweet during events, we welcome and encourage that. You can see our Twitter handles at MassHealthData and at MassHealth, as well as the hashtag for the event. All attendees will be muted during the presentation, and we ask that you submit your questions by chat. We will be providing a survey during the course of the presentation, and we ask for your feedback. We pride ourselves on presenting good webinars with valuable content, and your feedback is very important to us. You will be able to find a recording of this event and the associated presentation on our website, and as well as upcoming MHDC events. We encourage you to visit our website to learn more. Coming up on Thursday, February 9th, we are hosting session 2, month 2, of our Interoperability Executive Forum. This is a members-only event. We encourage members to join, and we encourage non-members to look at the options available to you to participate in what will be a monthly series of sessions throughout the year, breaking down interoperability, data exchange, topics much like we'll be discussing today. So please take a visit to our site and join us. We will be joined in February by John Kelly. John is a former executive with Harvard Pilgrim, has worked with the ex-governor or former governor Charlie Baker in reorganizing and bringing back Harvard Pilgrim healthcare from receivership some years back. He has been an executive with EdFX and is one of the most eminent speakers and most knowledgeable presenters when it comes to understanding interoperability and the importance of information exchange between and among payers, providers, and patients. Next page, please. I'm delighted to welcome Dr. Clara Filice, the Deputy Chief Medical Officer of MassHealth, and Sarah Kinn, the Deputy Director for Strategic Initiatives. Both bring a wealth of experience. Clara and Sarah, I will ask for a moment that you take a second to introduce yourselves and tell us a little bit about yourselves. You'll need to unmute your mic.
Sure, I can go ahead and start. Hi, everyone. Really pleased to be here today, and thank you for the opportunity. My name is Clara Filice. I'm a pediatrician. I'm the Deputy Chief Medical Officer at MassHealth, where I oversee our quality and equity value-based care programs. I've also worked a fair amount on accountable care organizations, our community partners program, and in our acute hospital space, in particular recently related to some of our equity initiatives. I have been at MassHealth for about 5 years, and prior to that worked in the federal government at the U.S. Department of Health and Human Services, and have practiced both in inpatient and outpatient settings as a pediatrician. I'll pass it off to Sarah.
Good morning, everyone. Sarah Chin, Deputy Director for Strategic Initiatives at MassHealth. What that means functionally is my team is responsible for the operationalization as well as a fair amount of policy development as it relates to our health equity efforts. One of the core functions of my team, and this has been an increasing and growing role, is thinking through the overall health equity RELD SOGI data strategy as it relates to our various different efforts, which is why we're so excited to talk to all of you today. Prior to working on health equity efforts here at MassHealth, I supported overall evaluation efforts related to our previous waiver, and in a prior set of roles worked for Boston Medical Center, thinking about autism-friendly care. And I've also done various different consulting roles and education-related roles. So very excited to be here today and also learn a fair amount from all of you.
We're very excited to have you both join us today. Lynn, if we can go to the next slide. So at this point, I'm going to turn it over, Clara, to you and Sarah to you, and let you move forward with the presentation.
That sounds great. And I'll start by setting the stage and talking a little bit about our broader health equity initiatives, and then pass it off to Sarah for the second part of the presentation focused on the data standards specifically. So next slide, please. Many of you probably know that Medicaid and MassHealth included is a federal state partnership. So when we talk about anything innovative we're doing in our Medicaid program, we typically talk about it in the context of authorities that we seek from the federal government, in this case, the Centers for Medicare and Medicaid Services. And one of those such authorities is our 1115 waiver, you'll hear us refer to, which is basically a vehicle that we use to implement innovative and progressive policies in our Medicaid program that otherwise are not available in the off-the-shelf Medicaid version. These are 5-year waivers from the federal government, and we just recently renewed our waiver for another 5 years. So beginning in October of last year through 2027, we have introduced a number of initiatives that we are just beginning to implement. So I'm going to talk a little bit today about some of the health equity priorities that are part of this new 1115 waiver renewal. Next slide, please. We had a number of demonstration extension goals. So the 1115 encompasses a whole host of delivery system reform and other initiatives. But one of the major priorities within it, in addition to reaffirming our accountable value-based care program with accountable care organizations, making new and enhanced investments in primary care, behavioral health, and pediatric care, really critical to our population. Supporting the Commonwealth safety net and maintaining near universal coverage across the state, as we are all proud of in Massachusetts. One of our major goals was really to continue to improve access to and quality and equity of care. And in particular, highlighted here are a couple areas of real prioritization within that related to what we refer to as health-related social needs, which many call social determinants of health or other social risk factors that are impacting health. As well as specific improvement areas related to maternal health. We cover a vast proportion of the births in the Commonwealth, as well as healthcare for justice involved individuals who are in the community. So we cover about 40% of births in the Commonwealth. And then we have a number of individuals who are in and out of carceral settings and have a high levels of healthcare need. There are a number of other areas in which we are promoting health equity beyond those, which I'll talk about in the next couple slides. So next slide, please. One of the big ways in which we recognize health equity will need to be advanced in the Commonwealth is in partnership with our healthcare delivery system. So while we at MassHealth are doing a whole host of things related to health equity initiatives ourselves, developing our structure and capacity for health equity, building up our data systems, which you'll hear about in a moment, tracking and monitoring disparities in quality, utilization, and other outcomes among our membership, we realize that to be successful, this needs to be a cross-Commonwealth priority and one that we really incentivize participation in among our healthcare partners. And so to that end, in this waiver renewal, we are promoting equity alongside quality as a core pillar of value-based care. In our previous waiver, we did shift, as many of you may know, about 1.2 million of our members into accountable care organizations that are at risk to deliver better health outcomes, lower costs, and improve member experience. And in this new 5-year waiver period, we will add equity alongside those other priorities as incentivized outcomes for our members. And we will introduce parallel health equity incentive programs to begin with, accountable care organizations and acute hospitals. And just as ACOs and hospitals currently take on risk for quality and total cost of care, they will take on upside risk for health equity as well, as we encourage them to build capacity and build infrastructure in order to support health equity well into the future. In tandem, we are accountable to the federal government for statewide progress on health equity. So we will be looking across our programs at key perinatal, preventive, pediatric, acute and chronic condition care, care coordination, and member experience outcomes to ensure that we as a state are continuing to progress on equity and reducing disparities that are observed. Next slide, please. There are 3 kind of major domains in which we are in this first year and into future years will be really prioritizing for the value-based incentives that will be provided for accountable care organizations and hospitals. The first, and this is going to be today's topic, is really focused on improving our demographic and health-related social needs data. We in Massachusetts, unfortunately, have pretty poor data right now on our members' race and ethnicity that's been self-reported. We have incomplete data on language, and we have very little data at all on self-reported disability status beyond that, which is required for determination of eligibility for Medicaid. Further, we have very little information on sexual orientation and gender identity. And beyond that, similarly on what we refer to again as health-related social needs. So housing insecurity, food insecurity, transportation needs, utility needs, experience of interpersonal violence. We've begun to screen our members through our health system partners for some of these data, in particular health-related social needs in our ACO program, but we have a long way to go. We also know that not only are these data incomplete in our own systems, but we know that many of our provider partners and plans similarly have incomplete data, which hinders our ability to understand and monitor inequities. The 2 other domains in which we will incentivize activity are the second domain is equitable access and quality, which is really around sort of what do you do once you've identified those disparities, if you have sufficient data to do so, analyzing the root causes of them, and then intervening on identified disparities to eventually reduce disparities in access and quality outcomes. And over the life of the 5-year waiver, we will really be shifting our emphasis towards disparities reduction and true differences in outcomes as we know our health systems become more capacitated to address them. And then finally, really thinking about capacity and collaboration. Health equity is not going to improve by the actions of a single hospital or a single health system. We really need to be thinking about what the interaction is across ambulatory, inpatient, and other settings of care, post-acute, et cetera, as well as within health system entities that serve populations in the same geographic areas in many cases. We will expect our health system partners and ourselves to make real progress within this 5-year period on health equity, and we really intend to take this as a learning opportunity. The field of equity improvement is relatively immature, but growing fast, and so as we incentivize and prioritize action on health equity, we really would like to see the successful stories replicated and the experiments that don't work out learned from, essentially. And we'll be really seeking to get sufficient data, reductions in disparities, and demonstrated commitment and capacity to support health equity into the future.
I have a question, Clara.
Sure.
Since you're framing equity and outcomes within value-based care and quality measures is such a key part of most value-based care arrangements, are you relying on any specific new quality measures related to equity or the intersection of equity and outcomes?
It's a great question, and one that we are in the process of developing now. So what we envision at a minimum is that we will, so these equity incentive programs will sit alongside and be related to our quality incentive program. So quality incentives in aggregate are not going away. But for example, in our accountable care organization program, while we have for a number of years incentivized reduction in or improvement in hypertension control, say, or improvement in prenatal care visits, we will, alongside that as part of our equity incentive program, be looking for a decrease in the disparities that we observe in those quality outcomes when disaggregated by race, ethnicity is the data that we have most complete right now, or in limited circumstances where we do have data on disability on certain populations. For example, we know that there are disparities in outcomes related to other risk factors as well, social risk factors as well. So that will be, so part of the equity program will be built on the chassis that is the traditional kind of quality measurement incentive programs that we've had for quite some time. In addition to that, we are looking to better measure, and there's a dearth of quality measures out there, but we are interested in better measuring other components and necessary processes in most cases related to equity. So one will be data completion, which Sarah will talk about a little bit more in a second, but looking at the progress that our health system partners are making towards more complete data and the improvements that are made year over year in obtaining those data in order to better understand disparities. Another set of measures will be related to disability access and accommodation, which is especially critically important for our MassHealth population, as well as access to qualified interpreters for those that are for whom English is not a primary or a preferred language for healthcare. So those are just examples of other types of metrics that we'll use. We would like to use only standard metrics in our health equity incentives program, as we typically like to pursue. We don't see ourselves as a measure development agency primarily. However, many of the metrics that we would like to see in our program don't exist yet. And so in some cases, for example, for data completion, we've specified our own approach to measuring data completeness based on a whole host of factors that Sarah will talk a little bit more about.
Great, thank you very much.
And Sarah, I'll turn it over to you to talk through our RELD SOGI standards.
Thank you so much, Clara. So now that you've heard the overall context for what we're trying to accomplish, it has likely become very clear why we need better and improved data. So what I'm going to lay out is what we are going to do to achieve that goal and the various different moving pieces that we have. Next slide, please. In order to improve the data that we have available, we are going to be pursuing two major initiatives. One is to really, through that 1115 waiver that Clara was describing, incentivize both our accountable care organizations as well as our hospitals to collect better data. Similarly, we're also going to be updating the MassHealth enrollment systems and eligibility systems to collect better data through that pathway as well. And we're looking to do these two efforts in parallel so that at least on the MassHealth side, we will be able to combine data across multiple sources to get the most complete picture of the population that we serve so that we can identify disparities and, of course, look to reduce those disparities. Next slide, please. In terms of figuring out what we wanted to do for data completeness and data standards, we have a few core principles that we're focusing on. First and foremost, we want to make sure that whatever we pursue is member-friendly. Some very specific examples of this is to the extent that we're asking about various different demographic variables and there's a choose not to answer option, we're phrasing that as choose not to answer instead of, for example, decline to answer. We want to be very, very mindful of our population and make sure that all of the questions and all of the data standards we're using are understandable, resonate, and are appropriate for our members. The second core principle that we followed in terms of identifying standards that we're implementing both through our systems as well as for our accountable care organizations and hospitals is to align to the greatest extent possible with national and also local standards. What this means functionally is really looking at, and I'll get into this in more detail soon, something called the Quality Measurement Alignment Task Force. And that task force is also looking at the various different national standards available, whether that is OMB or CDC, et cetera. So really making sure that we're aligned across the board with various different standards, as well as directional guidance that we, MassHealth, have received from CMS. So looking to ensure that the data across all of these various different intake methods is consistent to better enable us to combine that data and really use that data to understand and serve our members better. Finally, we really want to make sure that all of the various different changes we are implementing are operationally feasible. So really thinking about the various different timelines it takes to implement all of these updated but aligned standards, and thinking very, very carefully about how those updates are going to impact everything from claims processing to data sharing to EDI transactions and more. So really being very, very thoughtful about not just alignment with the member-facing standards, so for example, OMB, but also alignment with interoperability standards, for example, US CDI. Next slide, please. So in terms of choosing the various different member-facing standards that we wanted to apply both at the MassHealth level as well as to our accountable care organizations and hospitals, we've undertaken a very robust process. And this has been a multi-year effort to really make sure we're identifying the best available standards out there for our collective use here in Massachusetts. One of the things that we MassHealth have undertaken is we released an RFI, so that's a request for information, to gather and solicit information about what is the most appropriate and feasible set of standards. And this, we received 43 total responses from a range of different organizations. One of the other pieces that we undertook was to, in collaboration with some of our sister agencies, we procured a technical advisory group with representatives from payers, providers, consumer advocates, and more to really advise on the best member-facing standards for broad adoption across payers. And those recommendations have now been finalized and are available, I believe, publicly online and have been finalized by the Secretary Sutters as well. Next slide, please. So this particular effort has, as I mentioned, been a significant undertaking, and we've really wanted to make sure that this is a thoughtful and stakeholder-informed approach. So what you're seeing here is that we released the RFI and we also procured the technical advisory group as well. For the technical advisory group, they met multiple times, so over seven meetings over the course of the spring, and then those recommendations were presented to the overall Quality Measurement Alignment Task Force for their consideration, and also for a number of considerations related to member acceptance as well as implementation timelines. One of the other pieces that was also conducted is the Quality Measurement Alignment Task Force Technical Advisory Group partnered with MHQP to develop the specific wording of various different questions. And the exciting piece here is that was developed with interviews with consumers. So actually taking the various different questions and question phrasing and pressure testing that for acceptance and understandability and clarity with consumers to make sure that the various different questions are clear, are appropriate, are culturally sensitive, and more. So really being able to understand from that perspective as well. As I mentioned, those recommendations have since been finalized and are now available, and we MassHealth have, to the greatest extent possible, looked to align with those final recommendations across both how we're updating the MassHealth eligibility systems, as well as the requirements that we're putting in place for our accountable care organizations, as well as our hospitals. Clara, let me pause there and just see if there's anything you would want to add in on that description.
No, I don't think so. Thank you, Sarah.
It has been a very exciting and robust journey, and we've been very, very fortunate to have many experts and consumer advocates and more advise throughout this process, and think that we're landing in a really good place in terms of being very stakeholder informed and taking into account a number of different considerations across the board. So we're very excited about where we're landing at this point. Next slide, please. So let me actually talk a little bit more about what this means from a technical perspective. I've talked a lot about the member-facing version of these data standards, and that's what you're seeing here in terms of the descriptions. But when it comes to data standardization, as I'm sure this group is well aware, we have to also think about, okay, well, how is the data being described? So what are the value descriptions? How is the data being stored, and how is the data being sent? And what we're really looking to do is look at that entire continuum, at least from the MassHealth perspective, and make sure that to the extent we can, align across the board. So for example, what we're trying to do for race, ethnicity, and more is really leverage those US CDI codes that are already available to the greatest extent possible. And what you're seeing here in this far right column is that we have various different US CDI codes. These match up with the various different descriptions and value descriptions that you're seeing here. What you're also seeing here is how we have to store this information in the MassHealth systems, but what we have is a one-to-one map between those various different values and the US CDI codes, so that ultimately we will be able to combine and ingest that information from multiple sources. We're leveraging those US CDI codes because it is our understanding that that will be the most applicable and already adopted set of standards that our healthcare partners are using. I will note that there are some instances in which we've needed to add additional codes. So for example, we've added in UNK, so information was not provided or unknown, and also making sure that we have choose not to answer options as well. So just wanted to call out that we have those various different codes as well, even though USCDIA may not have those options already developed.
Sarah, we have a couple of questions for you and for Clara. From Rachel, Rachel asks, how do technologies like telehealth, remote monitoring, and digital access play into your strategy for improving equity?
I can speak to this. We didn't include it as part of this presentation, but certainly there are some notable interactions, I think, between the work we've been doing on telehealth and the work we've been doing on equity. So first of all, in the very early days of the pandemic, as folks probably know, like many other health plans, allowed for telehealth to be used audio only, audio video, or any combination of those two modalities to be used to deliver services to our members for any service for which a provider thought that was appropriate as a modality for delivery. We have continued to allow for telehealth to be used and paid at parity for almost every service that we deliver. The only ones that are excluded categorically are those that are simply impossible to deliver remotely, like anesthesia services or surgical services, radiology, CTs, et cetera. So we do see, and in particular, there's been a robust discussion, I think, internally and with our stakeholders around audio-only telehealth as the preferred mode of telehealth use for many of our members. We have some good data from our community health centers, our FQHCs, around audio only as preferred by many of our members, either due to digital divide issues or just preference not to be on a video camera during a consultation with the provider for whatever reason. So we have preserved that and continue to preserve that. We have prioritized equity very high on the list when thinking about what our telehealth policy will look like in the future. We also are in the process of introducing coverage for remote patient monitoring, which we do think there's promise and evidence-based suggesting value, especially for our members with chronic disease. As folks know, the most common settings in which it's used are typically to manage things like hypertension, congestive heart failure, other things where there is real value in allowing our members to avoid the inconvenience, time, effort, childcare costs, et cetera, that are required for many of them to come see their providers in clinic. And so to the extent we can support remote patient monitoring for those members, we would like to. And we also are in the process of, we're waiting for the CMS to finalize authority around e-consults. That's another area in which we know that for many members, having the primary care provider, for example, do an e-consultation with a dermatologist or another provider and not requiring the member to go visit in person both reduces time and effort associated with the visit and also in some cases results in more timely access to care. So we see telehealth as a potential that there is a lot of potential to make care more accessible and more available to our members. We also recognize that digital divide issues can have the opposite effect. And so some of our members who are more disadvantaged with regard to digital access may be less able to access telehealth services. So we're interested in continuing to build this moving forward. And as the literature begins to offer more evidence around the best ways to use telehealth, especially in a Medicaid population, we're eager to follow suit.
Thank you. Jennifer asks, are the QMAT data standards going to become requirements for MassHealth PCO participants, or are they just recommendations?
So the EOHHS Quality Measure Alignment Task Force, the QMAP recommendations are voluntary for voluntary adoption. So the recommendations are made not only on the health equity standards that we just described, but also annually, as folks probably know, the QMAT recommends a slate of quality measures around which plans can voluntarily align across the state. However, MassHealth, as part of our contracts with our ACOs, will set expectations for data standardization such that we can collect consistent and standardized information about our members across accountable care organizations and hospitals. So the QMAT standards themselves, again, are voluntary and intended for voluntary adoption across the Commonwealth, but MassHealth will set expectations for our own, within our own contracts that are consistent with those QMAT.
Okay, thank you. That's very helpful. We also have a question from Margaret, who asks, have you considered working with EMR vendors or using claims data to retrieve information such as diagnosis codes or demographics for ethnicity, gender, et cetera? And what are the pros and cons to that approach?
Sarah, I'll hand this one over to you or to others. I know Shaheen and others are on the call. You can talk a little bit about our work in this area.
Absolutely. So one of the core principles that we're thinking through in terms of all of this specific type of data, so race, ethnicity, language, disability, sexual orientation, gender identity, is the idea that it be self-report. And there's a significant value in that so that the member can actually report on their identity. And so really using that as a core principle. What we're also considering across the board is really making sure that entities have the opportunity to bring in this data from whatever source is self-report. So for example, one of the specific things we're encouraging is for accountable care organizations and hospitals to partner with each other. What we understand is many hospitals have fairly complete race and ethnicity data, and we not only encourage, but strongly suspect that those partnerships will yield better data in terms of actually being able to share that data. To the extent that that's coming in through an EMR or other platform, we're very much supportive of that to the extent that that data is self-report. One of the concepts that we heard quite strongly is in the context of, for example, disability in particular, what we're really looking for here is self-report disability. So leveraging what the member is providing to us rather than, for example, leaning on diagnosis codes for that category in particular. So really looking for the members to have the opportunity to self-identify through whatever mechanism is most appropriate. we very much encourage leveraging EMRs and other technologies to share and store that data to the extent that we're, of course, aligned with the various different privacy requirements and data sharing requirements. Clara, anything you'd add on that?
I'll just augment your comment related to disability, because I think there was another question in the chat specifically around why we are seeking more disability information when we do have eligibility determinations on the basis of disability that feed into our rating categories. And the reason for that is that the requirements for eligibility for MassHealth on the basis of disability are fairly stringent. And as a consequence, capture people only with with well-documented and a relatively high level of disability. And we know from the literature and otherwise that there is a lot more disability amongst our members, amongst individuals across the United States, that people would self-report a disability but wouldn't necessarily seek or be able to obtain eligibility on that basis. So it basically within it's a overlapping Venn diagram essentially, where we know within the broader category of members with disability, some of them are going to be identified as part of the eligibility determination, but there are a number of other folks that we anticipate would self-identify as having a disability that are not eligible on that basis.
Excellent. Thank you both for that. And I have just one more question. We've been getting them flying fast and furious across the transom here, but from Lewis, and Lewis, we've paraphrased your question, so we hope we cover it here, but what type of documentation are you providing on exactly what each data element means, how it should be interpreted, and which codes to use to report them on claims when appropriate to do so?
For race,
what types of
disability and SOGI, or for, I know there were also some questions from Lewis on HRSN.
Well, taking the benefit of the doubt, let's do both, right?
Why don't I start with the HRSN question, and then Sarah maybe can hit it too for the RELD SOGI. So for HRSN, we are kind of rapidly evolving with the field in terms of documentation of health-related social needs. We started out in this last waiver cycle, which ended last year, asking our accountable care organizations, for example, to screen their members for HRSN and to simply document the results in some place in the health record. We didn't even specify that it had to be in the medical record or in the electronic health record or medical record. And so as a consequence, some of our ACOs scanned in, paper documents that were collected in the clinic. Some kept them otherwise, they took a picture as like an other in the EMR tab. There were lots of different ways that the HRSN data were stored, and expected but unfortunate byproduct of that was that we aren't able to understand, synthesize, track, and monitor those data in any sort of logical way. The goal and the objective was to get screening beginning, and we didn't want to, necessarily require that right off the bat. In this waiver, we are moving, like many health systems across the country, towards electronic data capture of discrete health-related social need field information. And so there are sort of two major quality measures that are being developed right now that will be used to monitor health-related social needs screening. One is being developed by CMS, which provides a fair amount of latitude around how the data are captured. But if we were to adopt that screening measure, we would require the use of Z codes to capture those data, and would specify specifically which Z codes were allowable, what they should refer to, and what the response options are. The other is an NCQA measure that uses LOINC codes, essentially to capture health-related social needs screening information. LOINC codes are not currently included in our claims and encounters, so we don't have the ability to, MassHealth, we don't have the ability to use those currently to understand and monitor health-related social needs. And so I'll turn it over to you.
I'm sorry. Go ahead, Sarah. I'll let you finish up, and then I'll have just one more question to ask and allow you to continue after this.
Absolutely. Thank you so much. So in terms of the specific guidance around submitting this type of data, what we MassHealth will provide and have been working on is data specifications for data completeness. So what we'll have is exactly what would count in terms of the numerator and denominator for calculations related to data completeness. So for example, for race, what you would see here is which of these codes would count for the numerator and which would count for the denominator. In terms of the specific submission guide, we anticipate being able to provide a slightly more detailed version of what you all see in front of you today, which is going through and having the question wording, the question description. So for example, each of the various different member-facing options and how those would be translated into the various different US CDI codes. In terms of what we MassHealth anticipate taking in on various different data files, and actually we can maybe switch to the next slide just so I can show you what that would look like. What we would anticipate taking in on the various different submission files is what you see here on the bottom left-hand corner. So really bringing in those US CDI style codes and providing that information around how these various different codes translate into those member-facing questions. One of the other things I'll just note is, as you can tell, there are a number of sort of non-response style options, including choose not to answer or unable to collect or unknown. And one of the advantages here is we really think having this granularity in terms of these various different non-response options will enable us and various different organizations, whether an ACO or a hospital, to understand really what's going on with the data collection. So as we're looking at data completeness, then we'll be able to understand, do we have a sizable population that's deciding to choose not to answer? Or do we have a sizable population where for whatever reason, for example, the member might be in a coma, as an example. The information just cannot be collected, and really being able to differentiate across these various different scenarios so that we can understand really what's going on. And over the course of the next few years, really work on having that more complete information. And one of the pieces here is we know that the demographics, that the missing and unknown data isn't necessarily spread across populations evenly. We suspect that it may be our most disadvantaged members who are choosing not to answer. What we want to do is create an environment across the board where people are more comfortable. And so in those early years, if we're seeing a high percentage of choose not to answers, then that tells us that there's more that we can do across the board, whether that's at the MassHealth level, at a hospital, or at an accountable care organization, to really do a better job in terms of making patients and members feel comfortable answering these questions, and also making sure that it is okay not to answer these questions. So making sure that that choose not to answer option is always there, because some people just will not want to provide that information, and we want to make sure that no one is pressured to be in a situation where they feel uncomfortable giving information that they don't want to share. And so very specifically and deliberately, we are including choose not to answer as a valid response for data completeness, because our members should never be pressured to be uncomfortable in these situations. We very much want to do a better job of collecting this information so that we can do the best possible job serving our members, but not at the cost of making them uncomfortable.
Very good. I'm going to, go ahead, Clara.
No, actually, go ahead. Please go ahead.
I was just going to say, I'm going to stop asking questions on behalf of our audience. I've forwarded some to you. So if one of you is speaking, the other can take a crack at it. But I do know that we have just over 15 minutes left, and I wanted to be sure that you were able to continue your presentation. We have a lot of questions and people are very interested, but we could spend the rest of our time answering them. So I wanted to defer to you.
Yeah, absolutely. And I think, Sarah, you only have 1 or 2 more slides, I think. Is that correct? Yeah. So maybe why don't you just wrap up the slides, and then we'll begin to go through the questions, and I can kind of collate some of the similar concepts together.
That sounds great. I think in terms of this particular piece, what we'll note is, from a more technical side, we do really want to make sure that we're able to ingest appropriate data. So what we're working on is figuring out how and when we will either error out transactions or error out specific lines so that we get the most complete and accurate data that we can from a technical perspective. Again, want to make it very, very clear that choose not to answer is a valid option. These are all valid codes that we will accept, but just really talking about that more technical aspect of making sure that we can correctly ingest the data, and we're working through those various different pieces. Next slide, please. What you're seeing here is across the board, the various different questions, the various different categories of data that we've been talking about here. So race, ethnicity, English proficiency, disability, sexual orientation, gender identity, how those various different questions are worded, what data standards we are anchoring to. And I will note all of these are also aligned with the Quality Measurement Alignment Task Force, with the exception of English proficiency, as well as the various different member-facing values. So what you're seeing across the board is from a member-facing perspective, and that is different from the codes that would go in the system. You will see that there's a choose not to answer option and a don't know option for all of these various different questions. And that's how we're planning on implementing in our system, as well as how we would encourage our accountable care organizations and hospitals to implement in their systems as well. Let me stop there because I know we have a lot of questions, so very excited to continue to field those various different questions as they come.
And I can jump in on just as Sarah just described, the options that are included here include both several sort of non-response type of options, as one of you asked in your questions. And the question was, are we concerned that this will reduce our ability to understand our membership? Yes, the answer is yes. However, we heard very loud and clear from our stakeholders, and particularly from our member advocates, as well as from a number of other Medicaid programs across the country that have done a fair amount of testing in the field with Medicaid members and others around what the option should be, that it's critically important to offer a range of these sort of do not respond type of answers in order to make members feel they are able to fully self-identify with whatever the selection might be. So we did include a number of these. We at present will not we'll consider a choose not to answer option or a don't know option as being complete for the purpose of calculating data completeness, for example, with the expectation that simultaneously both we and our health system partners will be continuing to build trust and understanding around the purpose of collecting these data, which I think will take time. We all know that, in particular for segments of our population, those that are immigrants or for whatever other reason feel have experienced bias or discrimination related to a social risk factor, that they may not want to volunteer this information right off the bat, and that it may take time for them to feel comfortable enough to see how it's being used and understand the potential value for the for them individually or for the membership around reducing disparities. And so over the life of the waiver, we will continue to allow these options to count towards completeness, but really encouraging more and more self-identification, hopefully amongst our members through education, providing good workflows and appropriate workflows, cultural competency around asking the questions, et cetera.
Very good. I have more questions. What a surprise. This is great. I'm very pleased to see the interest and enthusiasm you've engendered among our audience members. One question is, if you're relying on self-reported disability data, how do you get comparable clean data with a standard meaning that can be used is useful? Self-reported means that anyone who feels like they're less able than they used to be could consider themselves disabled, and no one is performing an objective evaluation or comparison to norms.
So that's a great question. So we are specifically not using functional assessments or other objective measures of disability for the purpose of this social risk factor identification. We intend to use, as you've seen on here, there are 6 standardized disability questions recommended by HHS that ask, do you have difficulty seeing? Are you blind? Do you have difficulty hearing? Are you deaf, et cetera? And the purpose of this is not to identify for the purpose of clinical service delivery, for example, whether or not you need a personal care assistant or other services in the long-term services and support sphere. Those things will continue to require functional and other clinical assessments in order to receive them. But it is to understand the experience of somebody who believes they have a disability, believes they require accommodation for that disability, and see that as a hindrance to accessing healthcare fully and to the extent that they need. And so it's definitely not a clinical concept. It is a self-reported concept that we are seeking.
Also, I have a question from Eliza, who asks, what steps are being taken to convey confidentiality, providing member confidence and feeling comfortable providing this sensitive information?
This is a critically important concept, and one we've thought a lot about. We have high expectations as part of our contractual, agreements with our provider partners, with our plans, obviously internally, around confidentiality of these data. We are not going to specify with a high level of specificity how plans must do this, but do expect that they meet expectations around confidentiality that are required as part of accreditation, as part of our contractual and legal obligations otherwise. And we know that will require probably some new workflows and new systems and infrastructural changes around data exchange. And we also think that a big part of this is not only the technical side of confidentiality, but the way that these questions are asked, by whom, in what contexts, are going to be critically important. And that too, we think, is going to be a provider level decision and health system decision that will probably vary depending on the setting. Our FQHCs may take one approach, an inpatient setting may take another approach, and we think that's both appropriate and okay. In particular, I'll mention actually for health-related social needs, the one area in which this has come up not infrequently, and we think appropriately, is around this screening for interpersonal violence, which we think is critically important to occur. It may very well be asked only by clinicians in clinical settings, as opposed to on an iPad in the waiting room, as we would ask about food insecurity or housing insecurity or other things. And we, again, think that is, we want to offer discretion to our providers in terms of the most appropriate ways to ask these questions in the most appropriate settings and staff.
Excellent. It's a very important question and a great answer. Thank you. Lavanya asks, is there a suggested registration or clinical workflow to collect patient information? You addressed that a little bit just now in terms of not in the waiting room with a health aide or someone in a less than discreet and private setting, but are there suggested workflows to collect patient information that encourage good collection and a reasonable degree of patient comfort? Do you have sort of leading practices or recommended practices that providers can employ?
We will not specify what those workflows have to be. I will say that with the experience we've had over the last 5 years, having our ACOs screen for, in particular, health-related social needs, we have seen a variety of workflows, staffing, and other approaches employed, training, preparation, employed to seek this information from members. And we've gotten a lot of rich feedback on what's working best, the areas in which members are most responsive. Some members prefer to be asked in the waiting room. They want to fill it out themselves because it's easier for them to respond to it than if somebody's asking them directly. Depending on their language preference, there might be different workflows that are involved. We would like to offer our health system partners the opportunity to share those best practices amongst each other. And so we are intending to, we have in the past and will continue to in the future, have a series of opportunities that are, learning collaboratives for better. We haven't quite named them yet, but opportunities for providers to essentially share some of those best practices and learn from each other about what's working best. But we do see there will need to be tailoring according to population served, setting, and otherwise, and we want to encourage that. We don't want to specify one particular workflow that's required.
Terrific, thank you. Paraphrasing Andrew, who asks, only supporting 31 ethnicities is limiting. Are the 31 published yet? Do you know how many are likely to be other?
Yes, so this was quite a discussion actually amongst the Quality Measure Alignment Task Force. Because
Sarah's nodding. In
and Sarah, you can jump in too. You can go ahead. These 31 ethnicities were decided upon by expert consensus, DPH, and a number of other healthcare organizational leaders from across the state gathered about 10 years ago now to look at a whole host of different data sources, including American Community Survey, census data, which are not great, honestly, in terms of identifying ethnicities, mainly because the options are imperfect and don't necessarily represent everything that people would identify with. In particular, for Massachusetts populations, for example, there was no option for Cape Verdean or a few other ethnicities that people, we know we have populations that identify with those particular ethnicities. So the group sponsored by DPH put together what they saw as the most common 31 ethnicities in Massachusetts, including things like Cape Verdean and other things that were excluded from census surveys and otherwise, and put those forth as a starting point, essentially, to try to offer people options that resonated with them here in Massachusetts. We don't have like a gold standard source of data for people's ethnicities to use to help validate those options or to help refine them moving forward. But we are actively seeking additional opportunities and other ways to identify those. And as people offer for their granular ethnicity, if they want to offer additional things, we'll begin to collect data and capture data better on what these are. One of the reasons we didn't include, like FIRE has, Sarah can answer this question, like 600 ethnicity options or whatever, right? So we can't, especially for the purposes of many of our members still determine eligibility using a paper application. And so we don't have infinite opportunity to include every single option on, in particular, the paper application. It's less important. Obviously, people complete it electronically. Sarah, do you want to add anything else on that point?
Clara, I think you covered a host of the various different considerations there, and just to sort of highlight on that last point, operationalization is one of the factors that we were considering throughout this, and being able to have a list that you can actually put quite literally on a piece of paper or in a drop-down menu that people can leverage was an important consideration. Now, absolutely agreed that there are some limitations to this. So to the extent that various different partners, whether it's an ACO or a hospital or other organizations, have a specific population that they serve that they want to collect data on as well, that's absolutely something we would welcome and encourage in this particular realm. One of the other things, and you'll see this here on the screen for the race question, where we have some other race, please specify. We do anticipate actually collecting those pieces of data, and over time being able to see what are some of those additional categories that we might want to reconsider. One of the pieces here, and talking with this particular group, I think you will all recognize the implementation challenges. However, we're also recognizing that this is not a static effort, and that this is an effort we will need to revisit at some point in time, probably in the next many years, to make sure that we can update this over time to more accurately reflect the changes in our population. So one of the ways in which we can leverage that data that we're going to get from the some other race, please specify, is to really be able to, the next time we go through and think about what should the various different response options be, we can do that in a data-informed way, leveraging those self-response options. I will also note one of the other exciting things about this effort is per national guidance, for a lot of these fields, we're offering our members the opportunity to select multiple options. And this is critically important because what we're seeing is the demographics of people who identify with multiple races and multiple ethnicities is absolutely growing over time. So for race, for granular ethnicity, for sexual orientation, for gender identity, for all of these questions, our members will have the opportunity to select multiple options. That does introduce a number of questions around how exactly we're going to analyze the data, and we will therefore leverage national guidance on that as well. This is an emerging field, and we'll want to be very, very thoughtful about that, but it is so important for us to be able to give our members the opportunity to accurately reflect their identity, and that means being able to pick multiple identities. And that's one of the things we're really, really excited about here. And that's actually one of the things we hope will encourage better response options, because with the combination of these three questions, race, Hispanic ethnicity, and granular ethnicity, we hope and believe that our members will be able to better see themselves reflected in the response options provided. And to the extent that they're not seeing the appropriate response options listed, we're also providing those some other race, please specify options as well.
Well, Sarah Chin, Clara, Filice, I want to thank you for a tremendous presentation. This has been extremely informative. I know the questions that we've been asked to convey from our audience members have been thoughtful and thought-provoking. You're doing great work at MassHealth, getting these things lined up and organized and encountering the kinds of challenges that collecting and using this data present is a very noble challenge to take. And we appreciate the work that you're doing. I want to thank everyone for joining us. If we haven't answered your question, we have them. So we will forward them to Clara and Sarah for their follow-up, if that's fine with both of you. We don't want to be presumptuous, but there's a lot of questions here that are coming across the transom. Please take a moment to complete the brief survey. Your feedback is very important to us. And I want to thank our audience for attending our presentation today, and wish you all a less snowy and a warmer day today and going forward. Sarah, Clara, thank you very much for your time. And with that, we're adjourned. Take care.
Thank you, everyone. Really appreciate the time.
Thank you.
Thank you, everyone.